today I'm going to be explaining how we can recognise OCD, which is a clinical condition, and differentiate it from certain personality aspects that are not clinical and not a problem themselves. So OCD has had a lot of media attention attached to it in the last decade or so, and a lot of people now using the term OCD in an everyday language. So what I will be doing is explaining the difference between normal phenomena, so pickiness, cleanliness, and explaining how we know that from a clinical condition, how we can recognise it, how we can diagnose it. So the way we would diagnose OCD is going through a particular manual. The most recent diagnostic manual is the DSM-5, and that was published by the American Psychiatric Association in 2013. They set out 4 criteria that need to be met for a diagnosis. And if someone does meet all 4 criteria, the likelihood is they will come under that category. So what are those criteria? How do we know if someone meets it? So I will be pitching this for clinicians as well as anyone who may be a non-professional just interested in OCD. So I'll be explaining the characteristics, how we can recognise the signs, the symptoms of OCD, and differentiate them from other characteristics which might be, indicative of not a problem or indicative of a different condition, such as generalised anxiety disorder. So it's important to note right from the start that OCD is not as common as a lot of people think. So OCD affects around 1 to 2% of the general population, and that would be in almost any country in the world you would find that. So overdiagnosis is common, and a lot of people would see sort of minor symptoms of OCD, such as checking a light switch, rechecking it 2 or 3 times, taking up 2-3 minutes, and overdiagnosis can happen that way, but a clinical condition would be well beyond that, and I'll be explaining how we know if that's the case. Okay. So criterion A of the DSM specifies that frequent obsessions and or compulsions must be present for a diagnosis. So how do we know if an obsession is present, if a compulsion is present, and how do we know if it's significant? The first thing to note as well is that most people would have both obsessions and compulsions. It's very rare to have one or the other. Around 98% of people with obsessions would also have compulsions, and that can actually help with diagnosis. So how do we know if someone is harbouring obsessions? So how can we figure that out? I mean, the first thing to know is that the content of an obsession invariably comes under one of several categories. So it's a universal phenomenon that what an obsession contains will be the same as, let's say, in the UK as it would be in India or it would be in Australia. There are some minor variations in how common each theme comes up, but we can find that these are common themes. So there are several categories. So the most common category would be contamination obsession. So a person may have a worrying thought that they might have picked up a disease of some kind and may even pass that on to somebody else. Doubting is another common theme you would find in obsession. So if your client or you are experiencing thoughts of doubting, so did I turn the stove off? Did I accidentally leave the taps on? These are the sorts of themes that you may come across in OCD. Sexual obsessions sometimes come up, and they would comprise inappropriate thoughts about, let's say, did I rape somebody? Am I going to molest somebody? Am I sexually attracted to children? So it could be a sexual obsession. Rumination is one form of obsession as well, and it's somewhat different from the other kinds, whereby we may think back to conversations, what was said, and we would think over and over what the person said, what they might have meant by that, and that can sometimes come up. Religious obsessions can also occur. And it might be that the content of an obsession would be, I'm going to say something blasphemous in my church, or it could be some sort of religious indiscretion. Okay. Another, topic that sometimes comes up is somatic obsessions, and we may have repeated thoughts that we might have a particular disease, or that there's something wrong with our bodies in some way, and that's a thought that just keeps coming back and back and over and over. And aggression is another theme that can sometimes come up. So we might think, did I accidentally do something harmful to another person? Did I run someone over on my journey home? Would I stab my spouse? So these sorts of aggression obsessions can come up at times. And this is really the first part in recognising an obsession. First of all, would it come under one of these categories? And is it something that's frequent, that keeps coming back? And obsessions are essentially repetitive thoughts. They can occur as thoughts and words in our mind, but they can also occur as impulses, a feeling that we're going to do something suddenly, at a spur of the moment, out of the blue. They can also come up as images, so we might have mental pictures of doing something or something happening in our mind. So it can occur in any of those domains. So first of all, does you or your client experience any of these sorts of thoughts to do with these sorts of themes? Then this could be obsessions that we're looking at. The next part is to note that obsessions have particular characteristics. They are different from other repetitive thoughts, such as worries, such as depressive ruminations. And if a person has, to some extent, all of these characteristics, and there are 5 in total, we can then conclude that it's very likely that we can diagnose obsessions. So what are the characteristics? So the first characteristic of an obsession is that the way that it emerges in people's minds is in what we would call an intrusive manner. So it's something that pops in our mind unwanted. It would feel involuntary, as if we hadn't produced it. And it would just keep repeating back. It's an uninvited thought that we don't want. We don't feel we've consciously generated it. So that would be the first part. You might ask your client, how do these present? Do these just pop into your mind, or do you feel that you're creating these thoughts? The next one, the next characteristic would be the fact that these intrusive thoughts are very unacceptable. They're things that make us feel uncomfortable. They might make us feel very embarrassed. They might make us feel very anxious, very nervous. They may even make us feel panicky or depressed. And these thoughts will pop into our minds, and they will then lead on to this intense discomfort in our mind. Okay. The next characteristic is the fact that when these thoughts emerge, people with obsessions generally try and resist them. We try and suppress our thoughts when they emerge. And people might say, when it comes into my mind, I try and stop it, but it just keeps coming back. And ironically, often trying to suppress or resist our thoughts can actually intensify them and make them more frequent. The next part is the fact that these obsessions generally feel to the person as uncontrollable, something that I can't do anything about. I'm trying to stop them, they just keep coming back, and it can feel very overwhelming, and it can make us feel very, very bad as a result. The final characteristic is the fact that the content of our obsession would be the opposite of our core values. So if, for example, your core value in life is to keep your family happy and healthy, the obsession being the complete opposite would be, I'm going to pass on germs. They could be deadly germs, they could then kill my family. So they are the polar opposite of our core values. And we refer to that as ego dystonic or ego alien. They are very inconsistent with the way that our minds work and what our values are. Okay. Similarly, if you're very peace-loving, your obsessions might contain thoughts of causing harm or aggression to another person. So if you're noticing that these repetitive thoughts are coming, and all of these 5 characteristics or obsessions are also present to some extent, you are very likely you have now diagnosed obsessions. It's important to note as well that the degree or the intensity of the characteristics of each obsession would vary a little bit. So it might be that the suppression is there only a little bit, but the ego dystonicity would be very high, for example. What's also important to note is that intrusive thoughts, the thoughts that pop into our mind, are very common in the general population. Okay, and about 80 to 90% of the general population in any country will be experiencing them. What makes that different from an obsession is the way that people evaluate their thoughts. So people with OCD will evaluate their thoughts in a very negative manner, and that will then lead on to an escalation, that uncontrollability, that discomforting feeling, very unpleasant feelings that we're having, and that can then escalate. Okay, and important to note that only 1 to 2% with people with intrusive thoughts would have clinical obsessions, while much higher proportion would have them, but will be able to brush them off, be able to ignore them, forget them, and of course they're not going to escalate. They're just going to disappear, and that's going to be fine for most people. The next part is about compulsions, and compulsions are particular acts, they're things that we do, and invariably they serve to neutralise the distress caused by the obsession, or they might be used to try and ward off negative things happening in the future, so adversity. And as I was saying, the likelihood of someone with obsessions going on to develop compulsions is very, very high. So why we're doing it, and a lot of people with OCD would say, well, I do this to make myself feel better. I'll perform a particular thing and that makes me feel better. And they may even, most of the time, will say it's nonsensical. There's no real logic why what I'm doing makes me feel better, but it does. Some people don't realise that illogical feeling. So what are they? What are the most common compulsions? First of all, they would come under one of 2 categories, compulsions. So they could be things that we do in our mind. We would call them covert, meaning we can't see them. And they could be things like counting particular numbers, repeating superstitious phrases, or even things like repeating numbers in sequences, in orders, or even praying a certain number of times in our mind. And usually these sorts of things will emerge directly as a result of the obsessions. The other type of compulsions are overt ones, the ones that we can see directly, and they are the easiest to recognise because we can objectively look at them, see it's a behaviour. The most common types are cleaning, washing, disinfecting, and they're often linked to the contamination obsessions. And checking is very, very common, so checking that hob is off several times, checking that the doors are locked, the light switches are off, the windows are closed, checking and rechecking. Okay, and that will be linked to our doubting obsessions. When it comes to other obsessions, so things like sexual obsessions, thoughts of causing harm to others, we may reassurance seek, we may ask other people, did I do that? Did I run someone over? Or they may even confess. In some extreme cases, people might go to the police station and say, I might have been that person who murdered that famous person. That can happen in extreme cases, so confession or reassurance seeking can also happen. What makes a compulsion a bit different from any other repetitive behaviour is the very fact that we are performing it in order to neutralise the distress from our obsession, or used to ward off adversity. So if, for example, your client is saying, well, actually, I'm gambling and I keep spending money, that is different because what they're trying to do most often is attain pleasure, gratification, which is very, very different. They're not trying to relieve distress, they're trying to gain gratification. Other things such as tics, so people with Tourette's syndrome may have motor tics, they do think repetitive things over and over. Again, we know that's different from a compulsion because it's not used as a stress relief to get rid of that uncomfortable feeling, to ward something off. So if you can now find that your client or yourself is having obsessions and is then going on to perform particular compulsions, the likelihood is criterion A of the DSM has now been met, and now we can move on to see if the other criteria are in place for a diagnosis. So criterion B of the DSM-5 specifies that the problem needs to be clinically significant. And clinical significance basically means that some level of distress and disruption in our lives is happening. Okay. So if our obsessions, our compulsions are leading to frequent disquiet, anxiety, embarrassment, shame, disgust, then we can say that this is clinically significant. It's impacting that person's emotional health to a point where it's unpleasant and it's disrupting our life. The other way to know if it's clinically significant is it impairing our life? Is it getting in the way of working adequately, forming relationships, sustaining relationships, living in a family home without disruption? And we know that a lot of people with OCD, their lives would be disrupted because, let's say, they may be performing particular rituals which are taking a long time, several hours of the day, checking, rechecking, we're getting to work late because of this, I can't sustain a relationship because of this. So if it's impacting our ability to function normally, then clinical significance is almost certainly met in this instance. Okay, the DSM-5 gives the example, are you spending an hour or more performing rituals or compulsions? And if so, clinical significance is almost certainly met. Okay. So criterion C specifies that the obsessions, the compulsions are not better accounted for by a general medical condition, a substance or a drug. Okay, and for a lot of people, a lot of clinicians, this can really trip them up. Many of them not medically trained and wouldn't necessarily know. To make it easy, to make it understandable, I'm going to just simply tell you the names of the conditions that can lead to OCD symptoms, and then talk very broadly about knowing if it's medically mediated or if it's something psychologically mediated, as in OCD. Also, just to mention right at the outset is that obsessions and compulsions as a result of general medical conditions or a drug are very rare. It's very unlikely this will happen, but it does sometimes happen. Okay. The most famous general medical condition linked to OCD symptoms is Sydenham's chorea, and that is a condition, is a disease that occurs invariably in childhood, although it can surface in adulthood. And people with Sydenham's chorea usually have particular twitches in their faces and their feet, but they may also develop compulsions and obsessions as a result of their condition. Post-encephalitis is another condition which can lead to obsessions, compulsions, and encephalitis is essentially an inflammation of the brain, an infection. Once people have experienced it, reached recovery, particular portions of the brain may become damaged, lesions may occur in damaged areas, and those lesions can then lead on to the development of obsessions and compulsions. Usually soon after recovery this will happen, and remission can happen on its own after encephalitis, but sometimes it can be associated with it. Head injury, for example, can also lead to it. And some people may have had a particular trauma, a bang to the head, a road accident, whatever it happens to be, can lead to it. Partial seizures, so some people with a type of epilepsy during seizures may present with obsessions and compulsions, and they will be referred to as ictal phenomena. They're things that happen during that partial seizure. Anything that leads to calcification of part of the brain called the basal ganglia, so Huntington's disease, Barr's disease can lead to it as well. And both of these conditions can lead to obsessions and compulsions. Okay. And the lack of oxygen to particular organs in the body can also lead to it. And these, these can happen for various reasons. There could be injuries or whatever it happens to be. People may develop OCD symptoms after that occurs. And clozapine. So clozapine is an antipsychotic drug, or a neuroleptic, it's more also called. And in the UK particularly, clozapine is often seen as the last resort of treatment in people with psychotic conditions such as schizophrenia. And someone taking clozapine may develop obsessions and compulsions as a direct result of that. You would know from an interview, from a clinical interview, if someone is taking it. And people who are taking clozapine will invariably be going to a clozapine clinic, so they'll probably tell you about that. So how do we know if a general medical condition or this clozapine is causing it? First of all, does the person have it? Secondly, is there some sort of psychological reason behind it? So it might be that you are performing rituals because you are very discomforted by obsessions, and therefore you have a psychological urge to do it. And for that reason, we could say actually there's probably a psychological need, so it may well be a psychiatric condition, i.e. OCD. If symptoms do not seem to be psychologically mediated, so it might be the person engages in repetitive behaviours, but it's not because they want to neutralise the distress caused by their obsessions. That may well be that the medical condition is causing it, and that obviously the person would need to be diagnosed formally with it. The gold standard would be, medical evaluations saying that there is a direct link. We don't always have the luxury of knowing that, but we can have a good guess from looking at the psychological mechanisms behind it. Okay. The final criteria in the DSM essentially says that the symptoms are not better accounted for by a different psychological condition. How do we know if it's a different psychological condition? It's simple. Does the person meet the 5 characteristics of an obsession? Is it intrusive? Is it uncomfortable? Does it feel like we want to resist that obsession? Does it feel uncontrollable, and is it the opposite of our core values? And if so, then probably we're dealing with an obsession. The clinching deal, or the clinching part of diagnosis is, are compulsions being put into our everyday life as a result of it. So if obsessions are there and the compulsions are there, we can say with a very high likelihood that OCD is present. Some of the conditions that might resemble OCD are anxiety conditions, so generalised anxiety disorder, for example. What we know is that worries, which are linked to generalised anxiety disorder, usually feel like they're a valid source of concern. We might say they're exaggerated, but we would feel that worry is being generated by ourselves, and we feel actually we have a reason to be worried. In obsessions, that would not be the case. They'd be popping into our mind. We wouldn't feel like we're creating those thoughts. And also, we would find them quite alien, quite unusual in OCD. Depression can sometimes present with symptoms that resemble OCD. So depressive ruminations are common in people with major depressive disorder, or dysthymia, or also known now as persistent depressive disorder. And that usually involves negative thinking about ourselves, about the world, about our future. We can tell that not obsessions by the fact that first of all, they don't have the hallmarks, those 5 hallmarks of an obsession, but also they'd be relevant to our moods. So, if we're very depressed, we would think how horrible the world is. So the theme itself would be different. Another condition worth noting is obsessive-compulsive personality disorder. And a lot of people who are diagnostic of it would say I'm a bit OCD. How do we know it's not OCD? Simple, obsessions and compulsions are not there, but there are personality features in obsessive-compulsive personality disorder, and they are perfectionism, orderliness, and rigidity, and those are sort of characteristics that would be affecting someone with that condition. It would also be persistent and pronounced enough to say it's getting in the way of my life, and that is different. It has a similar name, but obsessions and compulsions are not present in obsessive-compulsive personality disorder. Okay. Any other conditions? There are a variety of other ones that might resemble it, even eating disorders, psychotic disorders. The simple way to know are the characteristics, the hallmarks there, are the themes of obsessions there, and are compulsions present. Final word, and certainly when we're making a diagnosis, is that comorbidity or a coexisting psychiatric condition on top of OCD is common, is in fact the norm. Certainly above 50% of people with OCD would also have an additional psychiatric condition. The most common anxiety disorder alongside OCD is social phobia or social anxiety disorder. But depression and depression symptoms are very common also in OCD. In most cases, depression symptoms develop in response to the obsessions and compulsions. It's getting in our lives, it's causing persistent distress, and for that reason I'm starting to feel depressed. But sometimes it doesn't happen in that pattern. It might be just coinciding and it's nothing to do with it, or it may even pre-exist. So that is my final word, and I hope this video has been helpful, and I hope it will help any clinician trying to improve diagnostic accuracy, and I hope it's affected some additional awareness for anyone who's interested in OCD.